My name's Karl Stark. I used to be the business editor at the Philadelphia Inquirer, the health editor. I left the Inquirer about a year and a half ago to go to Penn, University of Pennsylvania, where I help teach people to write. I do a class on narrative medical writing and help a lot of professors write different things. It's kind of a fun gig. The health insurance I recommend highly. But my heart is still in reporting and in hospital finances in particular. Okay, so I thought we'd start with what kind of stories can you do with hospital finances, because that's kind of what everybody cares about. And there are great stories to be done on hospital CEOs, how much money they make. There have been some amazing examples in the last year. One gentleman got 49 million, another got 33 million. We're going to talk about how to cover that, how to find those numbers. And a pitch I'm going to make to you is that hospitals are just bigger than everything else. You know, we reporters spend a lot of time covering towns, but hospitals are far bigger in general, and they have incredible patronage. They have jobs. They have money they pay to insiders. They have board members sometimes doing business with the hospital. They have charity care, which is free care they're supposed to give to the community. And they have large investments, and they make a lot of money. And another cool thing you can do with hospital finances is get a hold of really great trends like cutting babies' tongues, which was a big surgery. These surgeries get really popular. I'm gonna go over how to find them, how to find those tips. But there are just so many great stories from hospital data. You can find who's doing the most gender surgeries, which is very controversial. You know, who's doing weight loss surgeries in the era of Wegovy and Mounjaro, these amazing drugs that cause people to lose weight? Like, who's still getting surgery? It's kind of an interesting story. I'm going to go over 6 basic data sources that will help you. And I'm going to talk about how to find human sources to do the stories. So it's been a really tough bunch of years for hospitals. 2022 was probably the worst, but it ain't great now. There's a lot of bankruptcies, and the people who are bearing most of the brunt are these standalone hospitals and public hospitals. Public hospitals are owned by the community, and of course those hospitals in rural areas, like half of them are losing money on operations. A bunch of them are at risk of closing. And when a hospital gets in trouble, what they do is they stop money-losing operations like baby delivery, mental health, various kinds of clinic for the poor, things like that. You know, cybersecurity was a big issue last year, and it's even bigger now with cyber health, the great cyber attack that's still going on, that has disrupted something like half of the billings in the entire country. And people or groups have had to basically get loans and all kinds of money to pay people because they weren't getting paid by the subsidiary United Healthcare. Labor is still the biggest problem in hospitals, and the biggest example of that are nurses. I mean, you know, nurses are getting $100,000 retention bonuses and $30,000 sign-on bonuses. Like, this is just an amazing era that we're living in. And these so-called day nurses are nurses that come, the hospital hires them, they're outsiders. They come in by the day, they're paid a fortune. You can track their payments, and we're going to go into how to do that, but that's a big trend that's going on. And of course, the staff shortages are worse in nursing homes. We're not going to deal a lot of time with nursing homes today, but whatever's going on in hospitals is kind of magnified in nursing homes. My 97-year-old mother-in-law was in a hospital recently, and she had to wait 24 hours on a gurney. And she's about 100 pounds. She's a really amazing person, and was born in a coal patch in West Virginia. And, you know, both of her children have advanced degrees and did a lot of great things in their lives. She's come up a long way, but here she is, 97. She's in Western PA, and she goes to the hospital with AFib, and they stick her on a gurney in the ER, and she's so cold, they keep asking for blanket after blanket. She gets up to 6 blankets. And they give her a bedpan, which is kind of humiliating, but she's like tough. And she's like, you know, this all will work out well. And she is doing better now. But my point to you is that ER this is called ER boarding. It's rampant across the country. And it's really a function post-COVID, and it's really gotten worse. And what happens is the hospitals don't have enough nurses. You know, they're paying all those big bonuses we just talked about. We can't get enough of them. So there's no rooms upstairs, and they can't discharge a lot of people to nursing homes because they're understaffed. So people clog up in the hospital, and that's why people wait, you know, hours on a gurney in the ER. And I encourage you to look at that story in your area because it's a very powerful story. Another thing going on with hospitals is they're merging like crazy. Okay, like 9 out of 10 US hospitals are now part of systems. And what they've done is they've gotten bigger and meaner, and they want to basically negotiate with insurers. And so just looking at the Q&A, yes, this is being recorded. There will be a recording afterwards, Nick. And what courses are available for us interested in writing about health insurance? AHCJ has a whole bunch of mini courses like that. And this is a course, but it's really like an hour-long course. So I think one of the best ways is to do it and to try these different stories and learn about these databases. And that's a great way to teach yourself how to cover health insurance. But we'll get more on that. Okay, so hospitals have merged like crazy, and when they merge, they raise prices and they shut down services. And they always say it's going to make the place more efficient and it's going to result in cheaper costs. And it never results in cheaper costs as far as we can tell. And there's a lot of academic literature on this. It's kind of humorous. And basically people of color and in the rural areas are the most hard hit by these mergers. Another interesting trend is that 5 of the top 10 hospital systems are now religious. 4 of them are Catholic and 1 is Seventh-day Adventist. And this has a huge effect on abortion care, contraception, LGBTQ care. The main players are like Ascension, Common Spirit, Trinity, Providence, and Advent. And you can sort of, this is just a factor that hospitals have really changed and become much more strident on this issue. And therefore, I think it's a good area to cover. There's been a lot of stories about how nonprofit hospitals are acting like for-profit. And by the way, everybody thinks nonprofit hospitals don't make profit. And that is not true, okay? Nonprofit is the IRS term for not taxed. So they are nonprofit in terms of taxes, right? But they have now become meaner and larger than their for-profit brethren. And there are a lot of examples of this, of hounding patients for payment. They move to rich areas and get out of poor ones. And there was this famous story where sometimes they have clinics for rich people who get like to the front of the line and get all this great treatment. And as I said before, they grow larger, and it's basically to get more money from insurers, but it's also to get higher salaries, right? So tracking your salary, your CEO salary is a really good thing to do. The whole idea of a hospital is changing. This is a graphic about outpatient versus inpatient care. And you see, only goes up to 2018, but almost half of care is outpatient now. See how it's growing every year? And inpatient keeps declining. And what I'm arguing here is that the whole definition of a hospital is changing. It's becoming much more, we have surgery centers now, we have all kinds of outreach to the community. And so really to cover hospitals and cover hospital finances, you need to look at the stuff going on outside the building and in the community. And there's more and more of that all the time. You know, COVID really sped up the trend, telehealth really sped it up. And there are things that are going to the home, like one of my favorites is dialysis and chemo. And Deloitte sees a 35% drop for inpatients by 2030. You know, if your hospital is building a new wing, you could ask the CEO, like, you know, what's the 30-year outlook for this property? Like, you know, from what we can tell, from what Deloitte says, you know, hospitals are going more outpatient than inpatient. And what are you doing? Why are you spending all this money? Fun questions to ask. And there was a terrific story, I guess this week in the Wall Street Journal about hospitals slapping billions of fees on outpatient care. So outpatient pays less than inpatient. So what do? They slap more fees on outpatient. And in this case, it's billions of dollars of fees. It's a really cool thing to watch. This is a story close to my heart because the government wants 80% of dialysis patients to get dialysis at home by 2025, or either in home or get a transplant. And there are tremendous roadblocks, right? There's Fresenius, there's DaVita, there's this whole system riddled with old rules. And everybody wants to be treated in their home, and most people don't even know this exists, right? So just writing a story about it, I think, is a public service, something you might consider doing. Okay, so we have a question here about nonprofit hospitals. It seems like they have parallels with private universities, which are also nonprofit. Yeah, I think that's a reasonable. I think it's a reasonable observation. Because everybody thinks they're lovey-dovey, and in healthcare they become, more and more avaricious, going after money, going after patients, all kinds of things like that. One of the big trends is the rise of private equity in hospitals, and this group, Medical Properties Trust, is the biggest landlord in the country for hospitals. And the way their business works is they will buy the buildings from a hospital and then lease them back to the hospital, generating millions in income, but it's all these extra expenses that the hospital never has to pay. And so you have these big cash crunches. Steward, which is in 8 states, including Florida. I love this because they found 3,000 bats there in a hospital in Florida. I mean, that's charming, right? I mean, spreading COVID, no doubt. I mean, I don't know. The bat removal firm sued the steward for $1.6 million in unpaid bills. So they had 3,000 bats. They didn't pay their bills. You get the idea. But you see how crazy this idea is. I mean, or at least controversial. You buy the hospital buildings, you sell them to an outsider, you get an immediate cash infusion, and then you lease them back. And that's just like, all those extra expenses to the hospital's bottom line, and a lot of people can't do it. Let's see, we have another question here. How is accessing data for nonprofit hospitals different from for-profit ones? That is a great question. We're gonna get to that shortly. That is a question near and dear to my heart. We will get to that. So I was getting all these notices from my gastroenterologist to get a colonoscopy. I know this is too much information, but I noticed a name change, so I looked them up, and it turns out that my gastroenterologist practice got bought by private equity. So I sent them a note. I said, well, you're gonna give me less propofol, or you're gonna cut the staff, or you're gonna do all these things that private equity sometimes does. And of course, they never responded. And now I know, don't get any more emails, which is, I recommend that as a technique. But my point is that private equity now controls like 2/3 of anesthesiology, 2/3 of gastroenterology. They're big in nursing homes. They're big in hospice. They do ambulances, which is kind of interesting. A lot of rural hospitals, dental practices. And the way they work is, it's a little bit like the last slide. They basically do a leveraged buyout where they take over your company, and they get a big debt. They do a big loan, which pays them back. But then the entity that they bought now has to pay back the loan, and that can create problems. So they try to make it super efficient, and they roll up a bunch of different practices or hospitals in the area to try to make it more of a stronger position in the market. And then they try to get out in 5 to 7 years. That's kind of the way they operate. But I would look for evidence of private equity in your area, and we'll talk about ways to cover that. This is just a slide that says that hospitals create an awful lot of patient debt, okay? And these are great stories where people just can't pay the copays, they can't pay, sometimes they have no insurance. And these hospitals hire collection firms. You can find them usually in like civil court cases. And you should get their policy because so many people, 41% of adults have debt, and many of them say they've been denied care. So and some cities are actually helping to pay for people's unpaid hospital debts, which is kind of sad. But this is the system that we have, and this is a great issue to work at. This is just a little advertisement for a government program called EMTALA, which is the Emergency Medical Treatment and Labor Act. And what it does is it prevents hospitals from sending patients to other hospitals untreated. So it's so-called dumping patients. So like if you got an uninsured patient, there's a huge incentive for a hospital to dump them on someone else. And you'll see examples where the hospital will pay people's cab fare to go to another hospital, right? And you can find these, and sometimes the government investigates, and the EMTALA investigations are in hospital inspections. You can also FOIA CMS for them. But I think it's a great way to look at how your hospital is really working in the neighborhood that it's supposed to think. I'm just looking at some of the chat. Okay, we got that. CMS is now making sure that info on PEs are transparent if you know where to look. Is there a similar thing for hospitals and home health care agencies? Geez, I mean, I do not know of any. And I just know one of my professors just did a study about how untransparent private equity is compared to even 20 years ago, 10 years ago. So I kind of doubt it. It's worth asking, and maybe it's something that you could teach me. Yeah, who's funding behind PE ownership? I mean, a lot of it are the typical players, and those are gettable if you look up the stories that I list on this issue. Okay, there was this great law passed in 2022 that prohibited surprise billings, and basically it was an idea that if you go to the ER and get stuck with an out of network anesthesiologist and get huge bills, trying to prevent that. But there's one big exception, and that is ambulances. And the government, the federal government, the congressional bill exempted ambulances from this. So high bills are still common. Why did Congress do this? They did it because a lot of ambulances are owned by towns and public agencies, but a whole bunch of them are not. So anyway, they didn't want to screw over the local ambulances, but a whole bunch of them are private companies, and the two biggest firms in the area are private equity owned. So those are two examples for you to look up, because those costs definitely tend to be higher. And if you've got one operating in your area, it's a great place to look. So this is just another way that hospital finances work, and they basically, when they get someone who's undocumented, from another country, they can't get them on Medicaid, and they don't get paid. And so a bunch of hospitals have been deporting their patients. In this case, an Allentown hospital tried to deport a woman to the Dominican Republic, and she was in very bad straits. And they ended up stopping this. People objected, and the company, the hospital backed down. But they're incredible stories. There was a case in Jersey City where this guy, this uninsured, this undocumented guy, spent 10 years in the hospital because no nursing home would take him. And he basically hung out there like it was a hotel. And they finally got him out by getting him citizenship. And then they got him Medicaid, and then they got a nursing home bed. So it's just an area that I think is rife for stories. Why do we care about hospitals? Like, they're like a third of the big healthcare market, and they just sell, they use a lot of costly stuff, and they sell bonds, and they have a lot of cash on hand. Ascension, which is a Catholic system, had almost $20 billion in cash reserves. And many of them are far larger than towns that we cover, like the city of Pittsburgh. The revenue is $685 million a year, and UPMC, the big hospital company in Pittsburgh, their revenues are $28 billion. I mean, it gives you a sense of the scale of difference and why it's so important to cover hospitals and hospital finances. This is just how I got into hospital finances. It was the Allegheny Health System in Pittsburgh, and they came into Philadelphia, and they bought 2 medical schools and 10 hospitals, and everybody thought they were geniuses. And we were noticing that they weren't paying their bills, and the nurses would go from floor to floor scrounging for bandages, and their water coolers were getting repossessed. And sure enough, they declared bankruptcy. It was the largest public nonprofit healthcare bankruptcy up to that time. And then we just learned a ton of great stuff about them. And including the fact that the CEO's wife commuted on the corporate jet from Pittsburgh to Philadelphia to go to medical school. She was the health reporter for the local television station. And then she met the CEO and they fell in love, and then she had this amazing transport to medical school. And there's just a million other things that the PR guy, we used to joke with him because he made twice as much as the US president at the time. And everybody made big bucks, like all the doctors. And that's one way they kept people quiet about how corrupt the place was they paid the doctors huge amounts, and they would hold malpractice meetings and discuss malpractice cases from Philadelphia and like the Cayman Islands and all over Europe. And the CEO secretly gave 50 grand to the high school of where his son was a player on the football team, and gave $50,000 of the hospital's money to upgrade the facilities. And the thing that really got them in trouble was a story we wrote about. They raided restricted research accounts to pay bills, and the top 3 executives eventually pled guilty and went to jail. And this is one of the great cases of like, watch the nonprofit board, because this board was stocked with like blue chip executives from Mellon Bank, US Steel, Heinz, and a whole bunch of other really smart people. And they basically passed on this whole thing and let it happen. And one of my tips to you is watch the nonprofit board. We'll get to that. Someone had a question about finding documents for nonprofit versus the other kinds of hospitals. It turns out there's only 3 kinds of hospitals: nonprofit, for-profit, and government, the public hospitals. And the nonprofit, why is this important? Because this is how you find documents. The nonprofit is the one where they're the ones that file 990s, the IRS forms that are tax returns, essentially, for where a nonprofit shows how it's benefiting the community because of its tax-free status. We'll go over that several times. For-profits are on the stock exchange, like HCA, and there's just a bunch of big ones that are, and they're really interesting because they tend to pay a lot more in incentives, and they're really interesting to watch. Let's take a look at. And then government is the smallest group. On the NIHCM story, I would love to know how you track those expenses using records. Penetrating the finances of the giant is a huge unknown for me and others, I think. Okay, great question. So when you go into bankruptcy, your entire life is an open book. This is the short answer, Kaylee. Whenever you see a bankruptcy of a healthcare organization, just go and look at the records, because they have to put all their expenses for the last like 90 days, and they have to do all that stuff. Yeah. So the 70, and this is another question: how'd you find the 70 million in misspent research dollars in Allegheny? So that was going pot of money by pot of money. So I would hear from someone that their money had disappeared, and then I would go and they would sort of send me records on it, and we would add it to the pile. And then I heard someone else the same thing, and they were systematically going through. So that was just old-fashioned shoe leather, but it's a good question. And anyway, so just continuing on then, for public hospitals are really the ones that are going away. And it's basically because locals don't want to subsidize them. They're still the biggest deal in the South, but as Medicaid expansion rolls on, they're replacing public hospitals. So if you have a public hospital, they're likely to be endangered. And this is a public hospital owned by like a county or by a government agency. And when they close, or when they're privatized, they end up treating fewer Medicaid patients because Medicaid pays the least, and so you really the poor really get socked when a public hospital closes. And it's a reasonable question. There's a lot of academic evidence on this, that privatizing hurts people of color and the poor the most. Okay, this is just a short slide. You can look at this later, but it's a few facts about hospital finances that matter when you cover them. One of them is they have a very low profit margin, like 1 to 8%. And you got to understand that pharma makes like a 25% profit margin. What is a profit margin? It's literally like revenues, like what percentage of revenues are profit? What percentage of revenues, revenues minus expenses, and then you divide that number by the total revenues, and that's your profit margin. And big pharma is regularly 25%. The only people who were that good, that had that kind of profit margin were like newspapers in the old days and organized crime. Organized crime is really profitable, I hear. But anyway, the more you rely on Medicare and Medicaid, the worse your finances are. So one great question to ask your hospital is, how much Medicare and Medicaid do you have as a percentage of your total? The more commercial business you have, from Blue Cross, from United Healthcare, those are better payers, and your finances are better. The more you have Medicare and Medicaid, the government is very chintzy about what it pays. And so what happens is the more you have, the more you treat the elderly and the poor, the worse your finances are. Yeah, nonprofits are tax-free. It doesn't mean they don't make profit. They make plenty of profit. And what are they? The definition of nonprofit is they have to give back to the community, right? It's called community benefit. So they have to do charity care. They have to do some Medicaid care. And so that's really the definition of a nonprofit hospital. And those nonprofits are run by boards. And many times the boards have no healthcare expertise. Like in my Allegheny situation, yeah, we had all these corporate titans, but none of them knew much about healthcare. And the one guy who stood up to the CEO was run off the board, which is kind of interesting. Okay, we have a few more questions. Let me just dip into them. What do you think of hospital claims that 3% is a basic benchmark of financial health, and any profit less than that is a problem? Also, what do you think of the CMS MedPAC claim that reimbursements are pegged to what a well-run hospital should require? Well, first of all, I'm not an expert, right? I'm good at covering this stuff, but I would definitely ask experts what a good number is. The problem with 3% is you don't have a lot of money to reinvest, right? It's very expensive to run a hospital. And you need to grow services, you need to buy expensive equipment. So 3% is really not a great number. And I think it varies by person on that. I mean, I would definitely ask experts that. That's really sort of beyond my ken. Let's see, CMS claim that reimbursements are pegged to what a railroad. Yeah, I mean, I don't know, man. Like CMS pays, like the problem with government payments is they're stuck in amber and they stick around a long time, and things change and they don't change as often as the requirements are. So I don't think you can run a hospital, you can't run a financially successful hospital just on Medicare and Medicaid, because it's very close. People say they lose money on Medicaid for the poor, and then that Medicare they make a little bit more money. It's like a 10, there's like a very narrow difference between the two of them. Is there an easy way to look up the breakdown of funding sources of hospitals, private insurance versus Medicaid? Yes, there is. I'm sorry to keep pushing answers, but if I go now, this lies madness. Hold that thought. All right. The first document I'm going to talk about is audited financial statements. Okay, this is the gold standard for assessing a hospital's finances. Okay, and they give them to a whole bunch of people, investors and suppliers and government agencies. So they damn well should give them to you. Now I'm going to give you ways to get around that and get them anyway. But if you ask for it, and if they give you a document that has color in it, it's the wrong document. If it's glossy and has color pictures, it's been sanitized of all meaningful information. You want the real deal, right? And then the big trick here is don't try to figure it out yourself if you don't have any background in finances. Go find 3 experts to review them and to point out holes in their numbers, and then use those reporting nuggets to drive to the hospitals. Okay, so if you forget nothing else in this session, remember EMA. Okay, EMA is the SEC's website where hospitals typically list their finances. And somebody just asked a question about, like insurance and a whole bunch of other things. The EMA, you can look up your hospital on EMA. You can find quarterly financials, which is very hard to find. It's very timely. Most financial numbers are late and old, and this is actually up to the minute. So you definitely want to check on EMA. EMA is mostly for nonprofit hospitals, okay? They do have some for-profits when they sell bonds, so you just need to look on EMA. And you can also track a whole bunch of other things on EMA. And there's a nice little EMA alert for events to happen to hospitals you care about. This is a link right to it. And there's even a number. This is like the only time in American history where there's a federal database with free support. So I encourage you, if you can't find your hospital, just call them up or email them. They're supposed to be pretty good. I haven't used them in a while. The second great document is the bond prospectus. Okay, this is a great document if numbers scare you, because it's kind of written in English and they have to come with all the problems that the hospital faces. So, for example, they're going to do market share. They're going to do how much by insurance carrier. They're going to do everything because they're selling bonds. The hospital sells bonds to investors, and they have to tell the investors all the problems and what their real position is, right? So they got to be honest about their financial performance. They got to be honest about competitors. They may disclose lawsuits. It's just great, and it's a great. There's the document. It's the middle part. I think it's called Management Analysis and the Bond Prospectus. But it's a really fun document to get, and I guarantee you, if you get this document and all these documents, you'll get a ton of stories. This is an example of something that, a schlub of a reporter found in a prospectus, that this Temple University Hospital kicked out all its old people from a nursing home in the middle of winter, right? And because they got out of the business, they were losing so much money in nursing homes. And they are being investigated by the feds for criminal conduct, basically, which is kind of like unusual, and was a big headache for them. All right, let me just check and see what other thoughts we have. Are there bond prospectuses for other healthcare subsectors? So a little bit outside my expertise, but if they sell bonds, they have to basically go on Emma. And I know some nursing homes do, but I'm not 100% sure the answer to that question, so I have to punt that. Okay, we're doing all right on that. Okay, so the third cool document is the bond rating report. And basically, a rating group like S&P and Moody's rates your nonprofit hospital. This is for nonprofit hospitals, okay? And it basically, the rating evaluates the likelihood of them repaying those investors for those bonds, right? So they have a lot of really cool stuff about how well the hospital's doing, what the numbers look like. They're kind of doing your work for you. And I would be a little leery of them because they're not perfect. They are paid by the hospitals. And in the big meltdown in 2008, they kind of missed the freaking boat, and they screwed up like big time. They were a huge reason why those mortgage-backed securities were so dangerous, and Lehman Brothers, got an A before it collapsed. But the point of that is that hospital ratings seem much more reliable to me, just having used them over the years. They don't seem to be, that was like some high-flying shit going down, and hospital ratings seem like it's more like steady business, and I don't know. That's just my gut feeling on that. I can take a look at it. Okay, and then here's the 990. This is a tax form. This is what nonprofit hospitals do to justify their tax-free status. Okay, so remember, nonprofit means no taxes or very few taxes. I mean, they might pay taxes in the cafeteria, like sales tax, but they don't pay land taxes. They don't pay the big taxes, right? And that's why towns hate them so much, because they don't contribute to the common good that way. But they have to file this 990 to show like what they're doing for the community in return for a tax-free status. Okay, this is where you find their pay packages. There's a whole section on conflicts of interest where board members who do business or insiders who do business with the hospital, great place to look. I mean, you can have like dramatic readings of that section, when your story runs. It has things like community benefit. They actually measure community benefit. They have the board members' names. And AHCJ runs this really cool site called hospitalfinances.org, where we focused on the most useful elements for health reporters. And it's kind of a summary of like what I just went through, like the pay and the conflicts of interest. Like if you want to look through a 990 and you want to know where the nerve centers are in a quick way, that's what we designed this website to do. And that's what I'm trying to do here in this talk as well. So just a few thoughts. I mean, you can also get them through GuideStar, and ProPublica has a terrific site. These are for all nonprofits, not just healthcare nonprofits. And Remember I said on Emma how rare it is to have quarterly financials? Well, 990s are filed like a year and a half after their, after they're filed a year and a half later. And so the financial numbers are really old on the 990. So I wouldn't use the financial numbers very much on the 990 because a year and a half in healthcare finance is like a century, and a lot of things can change. And so I don't recommend the numbers on here, but I do recommend, like, the salaries, the conflicts of interest. There's a line for the number of employees. This line line 5 on the front page lists the total number of employees, and you can actually track the growth of the place over time just by the 990. I mean, investment income is always fascinated me because they have a lot of it, and they pay a lot of money to people to manage it. And one great question for them is, how well do you manage your money? Let's take a look here at some of the questions. Let's put the questions in the Q&A. Yeah, that's a good thing. Go over to the Q&A. Yes, Medicare and most insurers don't pay ambulance companies unless they bring the person to the ER. The paramedic treats them in the home. They don't transfer the person to the ER. They don't get paid if they bring a person with non-emergent. Is there any wonder that half of transfer are non-emergent situations? Yes, that is the making some op-ed, Steve. Maybe we should keep going. Okay, do you know if part are required to make public their meeting minutes? Oh, great question. I don't know what the current thinking of that is. I know you can go to the board meetings, and I kind of encourage you to do that because you get a real vibe. Like, a lot of times the CEO just runs the show and the board members just rubber stamp stuff, and you get a real sense of that. And also, who on the board knows anything about healthcare, really, besides experiencing it? Like, it's really worth doing. Okay, just going back to the greatest hits of the 990s, I'm going to, Schedule H is where they show community benefit, okay? That's a big area of interest for reporters because this is what they pay back to the community for getting tax-free status, right? And there aren't many rules about this. We're going to talk about it more in a minute, but it's definitely something you want to just remember. Schedule H for hemorrhoid is definitely a place you want to look at. Schedule J is those highest compensated folks, beautiful to look at. Schedule L is the transactions with interested persons. That's the IRS term for insiders and board members. I know all these great cases of board members. You would be surprised how many people suck money out of a hospital, right? Anyway, we hospitalfinances.org. Okay, I talked a little bit about that. Charity care. I'm going to skedaddle through this. Okay, so the most common story from the 990 is probably the salary story. And this guy, Kelby Krabenhoff, got $49 million from Sanford, and the Centera CEO got $33 million. And those were basically because they retired, and often there is a big bump when these egregious folks retire. And so I would encourage you to take, to look at that. When somebody goes, there's often a big salary. The trick to doing salaries is benchmark them. By that, I mean, compare them to hospitals of similar size in your area and see how everybody shakes out, right? So you're comparing like to like. And Modern Healthcare does this, and there's a bunch of other places that do. The other key thing for a salary story is look at the performance of the hospital or the system during when this person got a huge pay increase. Is their pay increase justified by better performance? Or did it go down the toilet? I mean, that's a really good story. Like, somebody gets a big chunk and they really did a bad job, or their numbers are terrible. I think you can make that an issue. Okay, Schedule H is community benefit. And the IRS, this is the weirdest thing because the IRS defines community benefit with two things: charity care and Medicaid underpayment. When someone asked the question earlier, can you survive on Medicaid? And the hospitals defiantly say no, and they can actually charge the Medicaid underpayment part right here. And so that's the IRS sort of orthodox definition. And then in the next, on Schedule H, if you look at it, there's a clump of that where they go through charity care and Medicaid underpayment. And then to the right of that is what the hospitals want to say is their public benefit. So they'll include all kinds of stuff like their education, and there are clinics, and there, you know, a lot of PR kind of stuff. So it's kind of funny. There are no strict rules about like how much you're supposed to spend on community benefit, if you can believe it. The hospital lobby is very powerful, and I think you can argue that they've been able to keep the rules from getting too strict and really getting that. So, but take a look at this. I mean, when people have looked at it, like this Loan Institute, which is one of their causes of life, is to measure charity care in hospitals. And they basically look at the tax break and how much they give back to the community, and they find that most of them, you know, make money on this. And they basically get more than they spend on community benefit. So that's a good place to kind of do this. The Wall Street Journal did a similar analysis, and they found that nonprofits were worse than for-profits. Remember, I was saying earlier that nonprofits like aren't the cuddly things you think they used to be. And this is another example of that, that they're actually they're doing less for the poor and other things than for-profits, which is hard to believe. And then one of the things I noticed is if you have a big academic medical center in your area, they're among the lowest in charity care. They typically do very little charity care. And they kind of argue that their education is what drives their enterprise. And that's a matter for public debate. And it'll be interesting to see what people think about that. This is Schedule J. You know, a lot of juicy things in here, like all the treatments. I remember seeing a 990 from Cedars-Sinai Hospital in Los Angeles, and which is a very expensive real estate market. And, you know, like Steven Spielberg is on the board, and Jeffrey Katzenberg was on the board, and all these Hollywood directors. And they were giving doctors like $200,000 stipends to buy a house. You know, that's the kind of thing you can find on a 990. And then the conflicts of interest is really a really important issue for us. And there's so many examples where, you know, the Baltimore Sun found that 9 out of the 30 board members for the University of Maryland medical system, 9 of 30 had deals with the hospital. Like, you know, how can you like tell the CEO that they're not doing a good job when you are like a contractor, right? That's sort of the bottom line, what's going on here. And I think the sign of really bad boards are they let this stuff go on. And there's so many other examples like this Memorial Sloan Kettering. This is more the chief medical officer, and you know, he basically got millions on the side. But I think the conflicts of interest, people are doing more studies and more things. I think it's going to go up. So one of the things I said to you earlier was that nonprofits do not pay taxes, right? So there is big movement on to get them to pay something. And they call it pilots, right? Payments in lieu of taxes. And some people have gotten them to do it. And Yale pays $200 million a year, and Jersey has a law that says that all these people, you know, have to pay a little money per bed. And I would just look and see, like, you know, who pays in your area and who doesn't. Most of them do not, and they zealously guard this. They zealously guard this. This was my pitch to you. I've said it several times. You know, go to the board meeting, get them. It's really interesting to hear them talk about stuff. Do they get quality reports at meetings? By that, I mean medical quality. And I'm talking about performance, like readmissions or things that are measured by the government. They should get all that. Do they have term limits? In Allegheny, you know, Allegheny was run by a board guy who flunked out of Yale. He was the 3rd member of his family to be the board chairman. And his family goes back to the 3rd governor of Pennsylvania, right? And his grandfather was a steel baron. And he knew nothing about healthcare, except, of course, I guess when he experienced it. And he and the CEO would regularly sort of date women in the hospital who worked for them, and use the hospital as a kind of dating service. And he was a real playboy, even though he was in his 70s by the time I came on the scene. But you get all this sense by going to the board meetings, like, and diversity, like, yeah, like what are they doing with that? I mean, that's really an essential thing. And of course, people doing business with the place. This is an example from a 990 where this hospital paid over $40 million to firms tied to the board members. And for those of you who know Jersey politics, like George Norcross is like one of the kingmakers, and he has discovered that it's not enough to run Camden. That's kind of low bar, but he's chairman of the board of Cooper Health, which is a huge academic medical center in Camden. That's where the real money is. They spent large sums on lobbying. That's all in the 990, but you can also get it other places. And they use their lobbying to, like, basically get a whole bunch of grants, both federal, state, DARPA. They got more to treat the uninsured than any other hospital in the state. And then I love this, when we confronted them about the $40 million to board members, firms, they amended their disclosure and they cut the insider payments by 94%. And remember, I told you there aren't very strict rules in this area, and they thought they could get away with it, and they essentially did. This is just an example of nuggets you can get from the 990, where this sleep specialist got $10 million from a big healthcare center that had ex-Microsoft people on the board and all these hotshot Nordstrom heirs. And what did this person do? Did he put them to sleep? Did he hypnotize them to get $10 million? I mean, it's an interesting story. And then this is more for the data centric among you, but Medicare cost reports are a great way to look at hospital finances, because every hospital files them. Okay, and so this is really a great way to catch up for for-profits, and it details all kinds of money paid to insiders, a lot of stuff that's covered on the 990, but also you can check it here. There's just great stuff in here, and these are some examples of what people use cost reports to do, where, again, I told you, don't try to figure out finances on your own, find a Johns Hopkins prof to do it, right? And this person reviewed cost reports to explain the closing of a rural hospital, tell the story of what went wrong, right? And then the journal used it to look at hospitals' charity care and how little they were spending. And the New York Times used it to analyze nursing home profits in the broken star rating system. So you don't have to get this by yourself. Here's another example, though, before I get into the top 20 hospitals that hire the most contract labor. Remember, I was talking about how nurses are in such short supply that you need to go and they need to hire these day nurses. Well, that's what contract labor is. It's kind of like outsourced labor you contract with. And that's a line on the cost report, and Definitive Healthcare basically used them to find hospitals with the most contract labor. And some of them were some really unsurprising hospitals like Johns Hopkins and Barnes Jewish. These are big name hospitals that are using contract labor. I love this story because we talked about profit margin, and someone said, is 3% reasonable? And I said, well, maybe 3 to 8%, so you reinvest. Well, these folks were making 53% operating margin. So for every dollar they brought in, they made 53 cents. And another one made 45% profit margin. How do you figure this out? This is all on the cost report. And it turns out most of the ones with the highest profit margin were for-profit hospitals. So it's kind of the things they focus on. And this group, American Hospital Directory, they compiled the list, and I recommend, this one idea. So here's an idea for how to work with cost reports. If you're good with data, get them and use them. Okay. If you want to try it out, go to somebody who knows cost reports, like Rand does it. They're eager to work with reporters. The guy there is Christopher Whaley. I just checked, he's still there. Costreportdata.com is also open to reporter inquiries, and so is the American Hospital Directory. So you can pretty much say to them, here's what I want to know, and then check their methodology and scrutinize them. Don't just accept it, and work with them and see what you get. And that's a great way to get into it, to dip your toe in it, and then build up to doing your own looks. Okay, so one of the coolest stories you can do from hospitals is finding these growing treatments. And when procedures get hot, they just get crazy. I remember we were doing a story on stents, and this guy did so many stents that they called him Full Metal Jacket. And basically you can document that on the so-called hospital billing data. And hospital billing data is every time the hospital gets paid, they put in a bill. And you can actually go down there if you know ICD-10 codes, and you can pretty much find what are things that are growing off the chart. And in Pennsylvania, we use this data to document items left behind after surgery. which people, people love to know that. I mean, we had a guy who, they left they put in a stent and they had a 6-foot cord in him, and they forgot they had the cord in, and he went home and he was in pain for like 3 months, and he kept coming back and they couldn't figure it out. And then finally they did another x-ray and they saw the cord and they took it out. And that's the kind of thing you can find in these documents. I mean, this is how the New York Times did that gender surgery story. They used ARC data. ARC is a federal agency that collects like billing data from 20 states. And then you can extrapolate to the whole country from those 20 states. 23 states have, so in Pennsylvania, we have a group called HC4, which collects this. 23 states have something similar where they supply the billing data, they have billing data, and 8 more are coming. And if you don't like that, you can go to ARC, the Billing National Database. You can buy Medicare data, or you can go to firms like AHD and, sorry about that, or Definitive Healthcare and ask them to come up with a list of the fastest growing surgeries. I think like any data story, there are errors, there's missing data, you've got to be careful. How do you find experts? I mean, for my money, the best experts are in like either medical schools, public health, or business schools, because they just don't have, they don't have like a built-in incentive to lie to you. Hospital consultants are good if they're straight up, but they work for hospitals, so they may have a conflict. There are a bunch of people with the healthcare financial management. Sometimes if you get somebody from another area, they can talk about your area. That association is really good for that. Former hospital executives are good, but they're so seared by the experience of dealing with the media that they often are gun shy of us, and they don't, I don't highly recommend it. Let me just take a look at some questions. And FYI, quarterly financials are not rare on Emma. I totally agree with that, Paul. That's true. I didn't mean to suggest that they were. I meant to say the opposite, that they are usually on Emma when they sell bonds, right? One hospital we have is a nonprofit, but all we can find in the 990s is their hospital foundation. Should we be looking elsewhere? And this is a great question. So it turns out the names that they file under are old. And you might, and sometimes they're hard to find in the 990. Like the, Fox Chase Cancer Center is still called American Anthropologic something or other. So I would ask them like, what name is your what name is your 990 filed under? And you can also ask them directly. By law, they have to give it to you. If you go down there and you knock on the door, they have to give it to you like right then. If you email them, I think the law is like 30 days or they have a little longer leeway, but they still should just give it to you, really. They give it to everybody else. Okay, how to judge community benefit given this week's dispute between loan and AHA over loan report? I mean, that's a great question. And I would look at the specifics. I mean, the American Hospital Association is gonna, has a long history of responding in this way, and they resist it. And look at I would just go point by point and look at their objections and see if they open it up. I mean, I don't think, my experience dealing with the AHAs, they're not that persuasive, but I haven't looked at it lately, and I would encourage you to go line by line with their numbers and check it with loan and check it with some outside experts. Let's see here. Okay, with many large companies like United Healthcare having different lines of business, it's amazing how many times one subsidiary of a large company pays another subsidiary of the same company. It's one way that health plans. Yeah, Steve, you got lots of great ideas. I mean, this is definitely, there are rules against paying below market, I think. It's one way that health plans can stay above the rules about medical loss and profits. Yeah, 15%. Yeah, so insurance companies have to spend 85% on healthcare. That's what he's referring to. And they had trouble doing that during the pandemic. Now they don't have trouble doing that. Any other questions that people want to, like before we go? We are right up against it. Here are some experts you can look at. Karl, I know these people are responsive. I do work at the same institution as Paula, and she helped me actually with some questions for this presentation. So I know she's legit, but I don't care if you go to her or not someone else. There's a lot of other people, and this is a short list of people who get quoted a lot and are really good on this stuff. And here's a similar list on 990s. A lot of them are law professors, lawyers, And they can sort of help you parse through things on, community, the hospital accountability project, a community catalyst. They were into this before loan, so they might be helpful to you. Let's see here. Things in the chat. Check to see if local hospitals got in trouble with filing EMTALA. Yes. Possible stories is how and why hospitals have shifted to more outpatient mental health care. Yeah, so you get, just a reminder, you get EMTALA by looking at hospital inspections, and they're usually online in every state. And we actually, AHCJ has a website that collects them, but it's down at the moment. But when it comes back, you can take a look at that. Can you share the previous slide? So was that the health policy experts? Is that what you were looking for? Can you provide a direct link to the PowerPoint? I'm gonna boot that one to my colleague, my excellent colleague, Catherine Reed. And I will send it to anybody who wants to email me. It's just carlst@upenn.edu.
Carl, if it's okay with you, we can post it alongside the recording this afternoon.
Excellent, excellent. Thank you for coming out of the ether and explaining that. I'm just looking to see if there's any other last questions. So sad hospice has become a business that leads to limited care for dying patients. Yeah, but great thing to write about, and documenting how it's different. Will you send slides out? Yes. Will these presentations be available to us? Yes. I know I went through a lot of stuff really quickly. My pitch to you is basically, if you look at the 6 documents, you'll get a lot of stories. And I would try 1 or 2 of them as a test, see if I'm lying, and see what, about places that you care about. How do I judge whether the nonprofit hospital CEO salary is too high? The hospital has no debt, lots of cash, and safe surpluses. How much is too much cash on hand? Is it good management or red flag? Great question. So one way we judge is comparing like hospitals to like hospitals. So compare similar size hospitals. One of the things we look at is like Children's Hospital of Philadelphia pays a lot more than Boston Children's. Those are 2 like hospitals, and that's one way to tell if they're doing. So they have no debt, lots of cash. I mean, I would get like a finance expert to look at their finances and give you like a little bit of an analysis, because that's what they're saying, and that's like, how much is too much cash? I mean, I think you need, like, in order to get paid bonds, they want to see several hundred days of cash on hand. So there's the bond raters have an opinion on that. You can reach out for them. Is this good management or a red flag? I think it requires more reporting and comparisons, and I think it's a good thing to think about. Any last minute questions? Not there. Not there. All right, folks, it's been a pleasure, and I hope to see you. AHCJ is having its annual conference in June in New York. I hope to see some of you there. It's a great time to learn a whole bunch of stuff like this. It's the great thing about AHCJ is just how much people share their expertise and what they do with it. So have fun. See you later.